next speaker today is Program Director of the Alpha-1 Association's Genetic Counseling Program. She has her BS degree in biology with a minor in psychology and her master's of science degree in genetic counseling. In 2007, she joined the Alpha-1 Association's Genetic Counseling Program to establish that program under Dr. Strange at the Medical University of South Carolina. She's got a long introduction. She's developed the association's genetic counseling into a model for other rare genetic diseases, and she's also a research coordinator and a principal investigator in multiple studies related to Alpha-1. She's counseled more than 1,500 alphas, family members, and healthcare professionals on understanding Alpha-1, including the risks and benefits of testing, interpreting test results, how to deal with the impact of an Alpha-1 diagnosis. Please welcome Dawn McGee. Here you go.
Good afternoon, everyone. So first I want to make a little announcement. I was given information from one of our patient's caregiver about the lung transplant group having a meeting. For anybody that's interested to learn a little bit about the new lung transplant program at MUSC, it's on November 8th at the Ashley River Tower Clinic Conference Room. And it's at noon on the 8th, and anybody who's interested in getting some information can call 843-792-9207. So today what I want to talk about is, and Jonathan talked a little bit about this earlier, is that November is Alpha-1 Awareness Month. So I'm just going to give a little bit of background about that, and then talk about the genetic counseling program, what I do, the services that I can provide, and talk about some of the experiences over the last 4 years of calls from family members. And then talk about how the genetic counseling program can help with family awareness, and that's a big part of Alpha-1 Awareness Month, as well as detection efforts, how to find all the alphas out there and get them diagnosed so we can get them the treatment and services they need. So November is Alpha-1 Awareness Month, and in 1999, President Clinton declared Alpha-1 Awareness Month nationwide. It has become a major grassroots effort led by the association, supported by the foundation, as well as the COPD Foundation. And the 17th Surgeon General declared Thanksgiving every year to be National Family History Day. And so what that was designed to do is to get everybody at Thanksgiving coming together with their families and sitting around and discussing their family history. So often we don't know what we're at risk for because nobody wants to talk about different conditions that they're diagnosed with in their family. They keep it very private. People that have risks for cancer, they don't know that they have these increased risks for cancer and could benefit from screening because nobody in their family talks about that diagnosis. And so by declaring Thanksgiving every year to be National Family History Day, that gets families to sit around and talk about what's going on in the family, what diagnoses are there, and what are we at risk for so that we can help keep our family members healthy and get them the screening and the diagnosis that they need. Therefore, Alpha-1 Awareness Month being in November fits really nicely with that. So again, that's a way to come together at the holidays and sit around and talk to your family members about Alpha-1. Let them know about your diagnosis, what your symptoms are, what's been going on, so that those family members that don't know about it can get tested and figure out what their risks are, and so that they can do things and change their lifestyle behaviors to keep themselves healthy. So here's the website for the association about their family for Awareness Month. And Jonathan talked about the Ripples of Hope campaign, discussing ripples, splash, waves, and these are all different things that you can do. You know, on November 17th, the association is asking that everybody put an Alpha-1 fact on their Facebook wall or Twitter, and to change your profile picture to the one that the Alpha-1 Association has on their website. So to get everybody putting that on November 17th, and then think of your list of friends that you have on Facebook. So if you put a fact on your wall and you change your picture, then everybody that's friends with you on Facebook is going to see that, and that's going to make them aware of Alpha-1, and that's going to raise and increase dialogue and initiate some conversation. And then if they see it and your friends and families decide, you know what, I want to post the same thing, and they post it on theirs, think of the impact that we can have virally on the web of letting everybody know about Alpha-1, and that's just one day of the month that we can do something and make a big difference. So some facts about how successful Alpha-1 Awareness Month was last year. Governors from 15 states declared November Alpha-1 Awareness Month last year, so that's fantastic. We're hoping to increase that number this year. 140 Facebook members changed their photo and put an Alpha-1 fact on their wall on November 17th last year. And again, think of all of the people that are friends with them that saw that and increased in awareness. And there were many individual alphas around the country that created awareness by educating their family and their friends and their local community and having different fundraising events throughout the month. So it was a great success, and we want to take what was done last year, learn from that, get some ideas, and only make it even bigger this year. You know, anything that you do to raise awareness, let the association know about it, and they can put that on their website. And again, that just helps give other people other ideas of ways to increase awareness. So now I want to talk about what I do. For the past 4 years, I've been working at MUSC doing the Alpha-1 Association's genetic counseling program. It's toll-free and it's confidential, so I take calls from people all over the country, as well as some from Canada. And anybody that needs to talk about Alpha-1, get some information, there's no specific thing that we're going to talk about. Any questions you have is a reason to call. So, you know, every call is different based on what your needs are as a caller. But what I'm going to do is just describe a typical call that we might have. And so the first thing I'm going to ask when you call is, what is your reason for call? You know, what are you looking at? Is it one specific question you just need an answer to, or do you have a lot of questions? Or, you know, are you feeling a little depressed today, or you just need to vent, or, you know, you're a caregiver and you're having a hard time today and you just need somebody to talk to. So there's all sorts of reasons why you would call. And so, you know, let's say it's somebody who's just been diagnosed and they're feeling very overwhelmed. And in fact, before getting their test results, they hadn't even heard of Alpha-1. So they're not sure what all of this means, other than their doctor said you've got Alpha-1. So we're going to review your medical history. What got you to where you are? What are your symptoms? When did you start getting sick? And how are you doing right now? So we'll review your medical history, and we'll discuss the genetics of Alpha-1, because Alpha-1 is, in fact, a genetic condition. So we're going to talk about the M, the S, the Z. What do they all mean? What are our genes? How is it inherited? What are the risks for family members? Because it is hereditary. We're going to discuss the different genotypes, what's the difference between MM versus ZZ and everything in between, and talk about what it means for these different genotypes. We discuss the symptoms, the clinical features of Alpha-1, and discuss the different types of testing. As you all may be aware, and if you've heard me speak in the past, I've talked about the different types of testing. The difference between a serum test versus a genotype versus a phenotype. What do all these words mean? And what is the difference between all these tests? Because each test is different in what it's doing, and it gives us a little bit different information. So what does all of it mean? And we discuss clinical testing versus ACT testing. The ACT study is our confidential testing study that's a research study done at MUSC, where we provide free and confidential at-home testing. And so discuss how is that different than being tested in your doctor's office, even if it's done through one of the industry-sponsored testing kits that are free as well. So how is that different, ACT versus clinical testing through your doctor's office? We discuss the benefits and the limitations of genetic testing, because genetic testing is different than, let's say, having your cholesterol level measured or doing your blood pressure. So what are the benefits of testing, and what are some of the limitations? And that will lead to a discussion of genetic discrimination. What is genetic discrimination, and what are the potential risks? Which then opens the door to discuss some legislature like GINA. What is GINA? What does it provide protection for? And what are some of the limitations of GINA? Because GINA is a good law, but it doesn't provide 100% protection. GINA provides protection from in employment as well as in health insurance, but it doesn't provide protection in the realm of life insurance or disability. And Gene is for people having predictive testing, not for people who are symptomatic having diagnostic testing. And so these are all kind of the things that we need to talk about when we discuss the benefits and the limitations of testing. Because if you're going to undergo testing, you should be well informed about what you're being tested, what are the test results going to tell me, and what are some of the downsides of it or some of the limitations or risks, so that you can make an educated decision. We discussed the different treatment options that are available and recommendations for healthy lifestyle choices. We discussed the impact of Alpha-1 on the lives of our entire family. Alpha-1 is genetic, and so it affects our whole family. It's something that's passed through the family. And for those individuals in the family who are not at risk, like our spouses or family members that, let's say, have been tested and don't have Alpha-1, the diagnosis still affects them. It still has an impact on them, and we're going to talk about that. Talk about things like survivor guilt, and that's something that we can see in many different conditions like cancer, where if you have two siblings that are at risk and one sibling has the condition and the other sibling tests negative, that sibling that doesn't have the condition has it has a psychological impact on them as well, because they do have some survivor guilt. Why is it that I don't have it and my brother or sister does? So we're going to discuss how this diagnosis is going to impact the entire family and change relationships and change the dynamic of the family. Spouses might have to take on new caregiving roles that maybe they're not comfortable with at first. It can have a financial impact on our family if one individual can't work any longer. It's going to have an impact on children. If they're young, they might have to take on new roles in the family. So we're going to talk about all of that and ways to deal with that and how we can overcome these new challenges in the family. I can serve as an expert resource for callers and for their family members in discussing testing and help to facilitate family testing. I think we can all think about different individuals in our family that are just a little bit stubborn about testing. They don't want to hear about Alpha-1. They don't want to consider testing. They're just in denial about it. And sometimes that really frustrates us, because we know how important it is to be tested, and we know how important it is to know your status. And so it really frustrates us when our child or our brother or sister just doesn't want to know about it and just doesn't want to be tested. And so, we can have a discussion about that, kind of what's been going on in the family, ways to maybe overcome that. But ultimately, it's that family member's decision of whether to test or not. And that's okay, and sometimes we have to accept that. Maybe it would help if you gave your family member my phone number and had your family member call me. Sometimes it's different hearing it from a third-party person than hearing it from your mom or your dad or your brother or your sister. So, we can discuss all of these ways and kind of brainstorm of how we can help increase awareness in our families. And also, there's so much information around testing and different ways to be tested and what are the different types of testing, that sometimes it can become overwhelming to have to explain that to our family members when we're just barely understanding it ourselves. And so I can serve as that resource that, leave that burden to me. Give your family members my phone number and I'll explain all of that to them. I'll talk about the types of tests and the benefits and the limitations and the different ways they can be tested, and help take some of that burden off of you when you're just still trying to come to grips with the diagnosis yourself. And I can also provide the support and the knowledge for callers to help educate their family members about Alpha-1. Give you the information to go and empower yourself and empower your family members to get tested and know more about Alpha-1. I can help individuals find physicians in their area. Mike talked earlier about the different clinical resource centers, the CRCs throughout the country can help you find a CRC in your area and give you the referral information you need, help you find the different services and resources and support groups. The Alpha-1 community is a very proactive community, and there's a lot of strong community sense with it, and I can help you get involved in that. Often when somebody's first diagnosed, their physician doesn't know much about Alpha-1, nor do they know a lot of patients with it, and so you often feel very isolated, like you're the only person in the country that has Alpha-1. Well, we know different. And so you can contact me and I will help you find all the services that are available and all the different ways to get involved. The association, the foundation, AlphaNet. and find a support group leader in your area, find ways to get involved with fundraising. There's so much to do, and I can help give you all that contact. I can help facilitate the decision-making process. I'm never going to tell you what to do. It's your decision, and there's often not a right or wrong answer. It's just what's best for you and your family at this point in time. And so I'm going to give you all of the information, the knowledge that you need, and the support for you to make the best decision that's right for you and your family at this point in time. And I can provide the psychosocial counseling that's needed. You know, how are you feeling? Are you feeling overwhelmed? Are you angry? Are you depressed? Well, let's talk about it and really see how you're feeling and help you to get the support that you need. And then we'll determine if a follow-up call is needed. Often when you get diagnosed, then you think about your spouse being tested or your children needing to be tested. So if you decide to go with the ACT study, then we'll determine once you get your test results, we'll have a follow-up call to discuss what those results mean and what that means for the rest of the family. So, as I mentioned earlier, the genetic counseling program has been in operation for 4 years now, and I have a confidential database where I log all of the calls that I've had. It's a way for me to track what's the data with our calls, who calls, and that way if you call again, you know, I can contact you again and we kind of know what's been discussed in the past. And so some of the things that I track with each call, one is, what's the category of the caller? Is it somebody that's deficient? Is it somebody that's a carrier? Is it somebody that's MM? Are they a family member? Are they a health professional? And when I first started 4 years ago, I would have thought that the majority of my callers would have been individuals severely deficient, ZZ, SZ, and then carriers and so on. And what I've seen is actually that the percentage of deficient callers is actually small compared to some of the other categories, one of which is family members. My largest percentage of callers are family members. And this means, you know, often what will happen is one person will be newly diagnosed and they'll give me a call, and we'll talk all about that. And we talk about the importance of family members being tested and what your family members need to know and ways that they can be tested. And so that first person I talk to will then go and educate their family members and tell their family members to call me. And so then I get all your brothers and sisters, your cousins, your children who will then call. And so the largest percentage of callers, as you can see right here, are family members. 30% of my calls have been from family members. And so this shows that the genetic counseling program can be very important and influential in your family awareness efforts and how to educate your family members about Alpha-1. And often then the family members are able to get all their questions answered that maybe you might not be able to answer some of these questions when you're first learning about Alpha-1 yourself. I also get a fair number of calls from health professionals, which I always think is great because that gives me a way to educate your individual doctors about Alpha-1, especially if they don't know a lot about Alpha-1. So this is a great way to let them know about it, how to care for you better, let your doctors know about the different resources available so that they can go and test other patients and get other patients connected with the community. And again, increasing detection. So another thing I ask is, again, remember the first thing I ask is, what is your reason for call? So what is the initial reason for your call? And if you see, the two largest reasons are testing options and explanation of results. So this makes sense. Somebody gets their new diagnosis and they want to know, what does this mean? My doctor just told me I'm ZZ. What does that mean? And what is Alpha-1? So that's one of the largest reasons of why we call. What does it mean for you? And that opens the door then to what does it mean for your family members? But the other thing is testing options, and this coincides with the family members calling me. If 30% of my calls are from family members, often they're going to be asking about testing. So my mom has just been diagnosed, and she told me I need to be tested. What does all that mean, or why should I be tested? So a big reason of why people call is for testing options. Again, increasing detection and family awareness. And then I track the different topics that we discuss in every call. And this is just the top 10 topics that have been discussed in each call. So things like testing options, which makes sense if a large number of callers are calling about testing options. explanation of results, the meaning of the genotypes, the symptoms, inheritance, and then other things like treatment options, risks for family members, risks for offspring. And so this just shows, what are the big topics that I discuss in every call. But again, every call is different, and different things might be discussed. One call might be asking a lot about genetic discrimination and GINA. And other calls, might really just be a lot of psychosocial counseling of, I'm just having a hard time dealing with this today. And I feel overwhelmed, and I just need somebody to talk to. So to date, in the past 4 years, that there have been over 700 ACT kits that have been ordered through calls with me. And out of those 738 ACT kits that have been ordered, 459 have actually completed the ACT study and received the results, which then means that there have been 406 follow-up calls made. Some individuals don't request a follow-up call, so then I don't. And some have been lost to contact if you move or change phone numbers or addresses and I can't find you any longer. But this just shows that, a large part of what I do and what I talk about is about detection efforts and family testing, and that over 700 ACT kits have been ordered, and that's a lot of family testing going on. So some of the efforts, as I've been discussing through the genetic counseling program for family awareness and detection, is that the association advises that individuals considering testing contact the Genetic Counseling Center prior to undergoing genetic testing, because we understand that genetic testing is a big decision and that individuals undergoing it should be well informed about the risks and the benefits and the limitations of testing. So the Alpha-1 Association advises all individuals to contact me prior to undergoing that so we can discuss that. And we're going to discuss, as I mentioned before, the benefits and the limitations of testing, the genetic discrimination and GINA. What is the appropriate testing? The ACT study tests for S and Z alleles, but for family members or individuals who have one of these rare null alleles or F or I or any of these other non-S or Z alleles out there, the ACT study is not going to be appropriate for you. And so that's why, contacting me first, we can discuss that. We can discuss what ACT can tell us and why that type of testing might not be appropriate, and what is another avenue to get the appropriate testing to answer the questions about what's going on in your family. And then we're going to discuss the possibility of various test results. It's often very important to have this discussion before undergoing testing, that you understand what I'm being tested for and what the possibility of test results are. I think often when individuals undergo testing, they think, I'm going to get tested just so I can find out I don't have it. And you just keep thinking, I'm going to find out if I have it or not. And you don't often think about, well, what if we know how we're going to feel if our results come back MM. But to really think about, well, what does it mean if my results come back ZZ or MZ? How am I going to feel? What does that mean for me? To really be able, so that when your test results come back, it's not such an intense shock that it wasn't what you were expecting. So a lot of our discussion before testing is really understanding that there are different possible test results and understanding what that's going to mean for you, and are you ready to handle those different test result possibilities. And then we're going to talk about, well, of these different possible test results that could come back, this is what it means for you, but this is what it means for your family members. This is what it means for your children and your siblings, your parents, how much your parents feel if they find out that they've passed something on to you. We know we can't control our genes and it's nobody's fault what we inherit, but often parents do feel a lot of guilt that they've done something. And so let's talk about that. How are your parents going to be able to handle this? How can we make sure that this diagnosis isn't going to negatively impact our family as much as possible? And certainly post-test genetic counseling is just as important as pre-test counseling, because now that you've got your test results, okay, let's discuss again, what does that mean? So what does the results mean for me? What do they mean for my family members? Should my spouse be tested? What are the risks for my children? Why would it be beneficial to test my spouse first before we test my children? Because if I'm ZZ and my spouse is MM, then we know all of our children are MZ and we don't actually have to test our minor children and have genetic testing for them. So these are all discussions that we can have if you call me after you have your test results and really talk about what does it mean for the whole family. Who in the family should be tested? Often we just think about our first-degree relatives, our brothers and sisters, our children, and our parents. But what I want to talk about is the extended family, aunts, uncles, and cousins, because there could be other people in the family that have Alpha-1 and don't know it, because we do know that you can have Alpha-1 and be ZZ and not get sick. So there could be people in our family that have the deficiency and don't know it, and they're healthy. So let's think extended family. And discuss the importance of family awareness in our families and ways to increase in family awareness in our families. What are different things we can do, different ways to educate our family members? So some of the ways that, and these are just different examples that I've discussed with different callers before, but one is, it can be a big burden to try to educate our entire family, our aunts, uncles, and cousins about our diagnosis, and after you've had the conversation 3 times, you're a little bit overwhelmed with having the same conversation again. So one thing you can do is write a letter and discussing your personal diagnosis and how you got to where you're at and the test results, and just sending that to your family members, letting them know about Alpha-1, it's in the family, and then putting in there links or phone numbers for the genetic counseling program, the Alpha-1 Association, the Alpha-1 Foundation, all the different resources, and have it in a letter to them. They can read it, and then it gives them the information they need to know, and then that lets them be able to contact me when they're ready. With the holidays coming up, this is a great time. Often people will, with their holiday cards, write a letter of, in the past year, this is what our family has done. Little Susie has gone to kindergarten, and Johnny made varsity on the basketball team. So this is another great way that you can say what's been going on. I've had this diagnosis of Alpha-1. It's something that's hereditary, and it's in our family, and this is why you should be tested. And that's a great way to educate the whole family in a really easy way. Another thing is at the family events with the holidays. And I'll show a slide of it. The Alpha-1 Association made DVD videos. It's 4 short videos talking about different aspects of Alpha-1, and they're 7 to 10 minute videos. This is a great thing. You can bring the DVD videos to the holidays, and when everybody's sitting around after they've eaten all the turkey and they're tired and they're sitting around the TV, it's a great time. You can put in the DVD and have everybody watch it, and it's a great way to educate your family members without you having to really give all that information. Another way is, even if it's not at the holidays, even if you want to just start small with your children or your siblings, you can arrange a time to view the videos. If Sundays are family dinner nights, at the next family dinner night, after dinner, just have a time to sit down and watch the videos, and it's a great way to open up that discussion dialogue with your family members about what is Alpha-1 and how can they be tested and why they need to be tested. Another way, especially if you do have, let's say you've got 10 aunts and uncles on each side of your family, and so you've got many cousins, and you might not be in contact with all of your cousins, but there's a few on either side that you do talk to. So one way is you can tell a few of your extended family members. Maybe your cousin Annie has 3 brothers and sisters, and you talk to Annie, so you could tell her, and then she can relay the information to her brothers and sisters. So that's another way that you can get the message about Alpha-1 and the family awareness out without having to tell every single family member. You can organize a fundraiser event and invite your extended family members to come and participate, and it's another way for them to learn more about Alpha-1. You can give your family members my phone number and just tell them to call me, and then I can give them all the information that they need. So these are some of the resources that the Alpha-1 Association has made about the genetic counseling program. We have 2 brochures about the genetic counseling program, and this one is designed for family members, and this one's designed for health professionals. So you can get copies of this and give this to all your doctors, and you can get copies of this and give it to all your family members. They're on the association's website, so you can just go on and print them out, or you can contact the association and they'll be able to send you some if you want to include them with your holiday cards or if you're doing mailings to your family members. And then these are the DVD videos that I mentioned. This is a copy of the DVDs, the 4 short videos that are on there. And they're also mounted on the association's website, so you can just go on and click on and watch the video from their website, or again, we have them in hard copy, and you can always contact the association and they'll send you some as well. And here's my contact information. Please feel free to call me at any time or have your family members call me as well.
Are there any questions? Okay. That means everything was covered well. Awesome. Pardon?
Okay, so thanks, Dawn. And now we're going into the last, but certainly not the least, section, which is an open forum with Dr. Strange. Q&A.
Well, guys, it's been a long day, hasn't it? So one of the interesting things that happened at this education day that y'all probably didn't know was that this new age of Facebook and Twitter is alive and well. So during this meeting, not everybody in America could come to Charleston, unfortunately, so they actually invited on the Alpha-1 Association Facebook page questions to be posted that could be held live during our sessions. So we had 4 questions come up, and I didn't want to deprive you all of the questions that were posted on Facebook during our period of time. So they videoed my answers to the questions and posted on Facebook, so the Facebook video of me in real time in our education day is now on Facebook for the Charleston Education Day. Isn't that cool? So of the 4 questions that came out, 2 of them were about transplant. We didn't really talk about lung transplant and what it takes. But 2 of the questions were about gastroesophageal reflux and why some centers don't let people in and others do, and where to go and all this kind of thing. And those of you that know about reflux know that historically this has been heartburn. Heartburn, and in the 1950s they thought it was due to eating acid foods and don't eat tomatoes before da-da-da. Now we know it's all about your muscle at the bottom of your swallowing tube, the esophagus, that as we all get older begins to loosen a little bit, and we have some of the stomach contents come up in our swallowing tube. It's called gastroesophageal reflux, and it happens with all lung diseases. When you and I start walking down the hall, if we've got lung disease, the pressure that we use to breathe puts a different pressure on the stomach and the lungs, and so we can send a little bit of gastric juice up into our swallowing tube, which is called reflux. Duke Medical Center up in Durham has been one of the centers that's kind of looked at the impact of reflux that is symptomatic with heartburn only about half of the time, and the other time is just happening even though you don't have any pain or any problems with your swallowing, on the outcome of their lung transplants over the next 3 years. And they found people that have a lot of reflux don't do as well with their transplants. And so they'll look at their reflux, they'll do swallowing studies and how much acid comes up. Got too much, they say, see you later, go somewhere else. And there are other centers that don't really believe their data, and there's not a whole lot of hard outcome other than what's come out of Duke about this. But that's why people's reflux is screened for during a transplant operation. Depends on how bad it is. It's all a matter of degree, but it rarely completely excludes everybody from transplants. But it's one of the many things that are evaluated during the course of transplant. The other question around transplant that was posted on the Facebook page was, well, they told me that my liver was too sick to get lung transplants. Is there some place I should go instead? And this is another situation where it's all a matter of degree. If I just told you everybody might have a little bit of scar in your liver as we pass the age of 50, then they can't not transplant anybody with Alpha-1 because we know that Alpha-1 transplants do just as well, if not better, than the other patients that have COPD that don't have Alpha-1. And so we've really looked very carefully. The database that is kept around the transplant world is a database from the United Network of Organ Sharing, UNOS, U-N-O-S. And UNOS keeps every transplant that's ever happened and how long they live, and every country in Europe has one of these databases as well. Some of you might have seen the latest study out of Sweden that showed that the lung transplant success rate is now out to 15 years in the Swedish population in the majority of individuals. Better and longer term transplant opportunities than what we have in the United States. So this whole issue of if you got too much liver disease, can you have a transplant, depends upon the degree. It's because most of the time we don't do two organs, although we could. We could put a liver and a lung, or two lungs and a liver into everybody if we wanted to, but that's a big, big operation, and the more organs we transplant at one time, the higher the complication rate is. And so it just depends on how much liver disease there is. They're going to look over, if you go for a lung transplant, if you have liver disease or not, and try and figure it out. But what they say at one center doesn't automatically translate to another center. There may be another center willing to take care of you with any given set of organ dysfunctions. And so it's all a matter of sending your stuff to one place. They don't like you, send it to another. There's one of the individuals who's in the room earlier who had been turned down at 3 transplant centers, so actually wrote the letter, says, I have a very challenging transplant for you good transplant surgeons out there. Is anybody willing to take this guy? And sent it to 7 centers. And one of them said yes. And so he was here today with his transplant, just because there's differences between transplant centers on what people are willing to have happen. Any other transplant questions before we leave that topic? Okay, good. What's the next set of questions y'all want to talk about?
Is there a correlation between portal hypertension and hypertension?
No. So remember, if we showed you that big portal vein that drains all the intestines and comes up to the liver. When the liver gets sick, the pressure goes up in the portal vein. That's called portal hypertension. If we could put a blood pressure cuff on the portal vein and pump it up, it'd be just like your arm. But those are two different places. And usually when the liver gets sick, our blood pressure actually goes down. We actually have lower blood pressure in the presence of liver disease. So pressure going up here increases our risk of bleeding and of the spleen getting bigger and our platelet count being low. But on the reverse side, our blood pressure is usually lower in the presence of liver disease. That's because the liver disease doesn't clean our blood of all those chemicals coming up from the intestines and sends some of those chemicals through that dilate some of our blood vessels. So if you see some of the liver disease patients, they're going to have nice red, warm fingers all the time and have some redness on their palms and sometimes redness across their cheeks. Their blood vessels are dilated, and as a result, their blood pressure is lower. So there's no correlation at all. In fact, it's actually the reverse. Next set of questions. Shoot.
My mother has real low platelets, and they're like 86. And once they gave her IG medicine, but they said her spleen was enlarged is the reason why that her platelets stay so low. But right now they're like 86. I mean, what else could they be done? I mean, can you live without your spleen?
Good question. All right, so a normal platelet count is somewhere around 150,000 to 400,000. And so hers being in the 80,000 is low, but it's not dangerously low. When we have individuals going through chemotherapy for a cancer or something like that, platelet counts will get down to 20,000 or 10,000. And so the risk there is for bleeding. These 80,000 counts are safe, but they indicate something's going on different with your body. So we take those signals and kind of think about what organ might be abnormal, and some doctor has found out that your mother has a large spleen. Spleen's one of those organs that we don't really know what it does, and it's just kind of been there for eons, and it's just kind of sitting there. It's full of blood, and we know that it helps make some of our blood cells, but if you're in a car wreck, it's one of those organs that sometimes gets lacerated, and surgeons go in there and just take it out and throw it in the trash can, and nothing bad happens to those people. You don't really need your spleen, and sometimes we go through and take out spleens in people that have big spleens and low platelet counts, and it cures that process. I'm more curious about whether she might have portal hypertension, some subtle liver disease or not, and whether she could have liver disease either on the basis of carrying a Z gene or whether this is all another liver disease and those sorts of things. So it, yeah. Yeah. Okay, so it's all these other diseases that can affect our spleen, myasthenia being one of those diseases that can do that, a very rare disease. Getting two rare diseases is fun, huh? All right. What else do we want to talk about today? Treatments for lung disease? What do you want to know about treatments for lung disease? What's new? So what is new? So there is one new medicine that's passed through the FDA this year. It is a new pill called a phosphodiesterase 4 inhibitor. It's got a brand name called Daliresp. Daliresp was a very controversial medicine going through the FDA last year. The FDA advisory board, which is a bunch of lung doctors that sit around the table, voted it down. They said, nah, we don't want this medicine coming through the FDA because it has too many side effects, and yet it went then to the FDA final review panel, and they said, we haven't had a new medicine for COPD in 20 years. Let's let this one through. The side effects are not that bad, and we need some new medicines for COPD. So it's one of those, you go against the doctors and you pass it anyway, and the other way around, the doctors think all these medicines are great, but they vote down the day after pill anyway, and those sorts of things are the type of fodder the newspapers love to talk about. Daliresp is a phosphodiesterase 4 inhibitor. It's very much similar to theophylline and Theodore and some of these older medicines that help open up your airways with a pill form, but have some side effects. And theophylline, Theodore was one of those most commonly prescribed medicines for COPD in the 70s and 80s. But if we give lots of bronchodilator therapy, some of our common inhalers, and then add theophylline medicines, then they don't do a whole lot more to most people, but there are individuals that have a tremendously good response to these pill forms of bronchodilators. Daliresp is different because it is just one of the 4 phosphodiesterase enzymes that doesn't have as many side effects as theophylline. And the worst side effect of this medicine as it came through was a 7-pound weight loss in the people that took it. And everybody says, whoa, that is for me. So there's just a little touch of nausea, but they're comparing it to placebo, the sugar pills. They're going through trials as well. So it's one of these things that I'm willing to give a month or 2 trial to see if breathing's a little bit better with this medicine or not. And by the way, if you lose 7 pounds, I'm okay unless you're skinny anyway with your COPD. So it's just one of those new medicines out there. The rest of them are all puffers and inhalers that are formed in one of 2 classes that are the beta agonists and the muscarinic antagonists. And those are just big doctor's words that say Albuterol and its first cousins, some of them long-acting, which are the beta agonists, are, let's see if I name them all, albuterol, levoalbuterol, brand name Xopenex. The long-acting, the 12-hour acting ones are salmeterol or Ceravent, and formoterol, Foradil. And that's our armamentarium of beta agonists. Salmeterol and formoterol are sometimes in combinations with an inhaled steroid. The inhaled steroid is either fluticasone, which is Advair, or, can I pull it out? They're recording me too. This is embarrassing. Formoterol and budesonide, the other steroid, which is Symbicort. So Advair and Symbicort are your two combination beta agonists and inhaled steroid medicines that you take every 12 hours. We have our short-acting albuterol, which comes as 3 different drugs, Ventolin, Proventil, or, y'all help me on this one, albuterol as ProAir, or Xopenex, which is an inhaler that doesn't cause quite as much shaking as albuterol. So that's the beta agonist stuff. Questions on beta agonists? I did get through all that, didn't I? All right.
Given the steroid piece, is
Yeah?
there a timeline that you should or should not be on it?
Yeah, so the inhaled steroids are different than prednisone, our oral steroids for this disease. And what this inhaled steroids do, they're our number one drug of choice for asthma. They take a real twitchy airway and make it easier to breathe. And the inhaled steroids decrease a thing called exacerbations. The number of exacerbation defined as need for a medicine for more mucus, more wheezing, or more shortness of breath, is about an average of 2 exacerbations per year in the Alpha-1 and COPD community. If you're having more than that, we need to decrease your exacerbation numbers. And inhaled steroids are the medicine that does that the best. The side effect of an inhaled steroid is that it really doesn't affect most people's weight at all the way prednisone does. But we do have a little bit of a signal where if you're on an inhaled steroid all the time, you have increased pneumonias. If you're decreasing your exacerbation frequency, using less antibiotics, not getting sick as much, why would you have more pneumonias? And that one we think we understand a little bit, but it's just that you have fewer events, but when you do have an event, it's a pretty bad event. And so the pneumonia frequency is common to all inhaled steroids as part of the package insert of all of those medications. We think they're very safe medicines. They're the drug of choice for all those kids with asthma out there. So they're very safe medicines. They've had 25 years on the market, and we think an inhaled steroid should be part of most people's regimens. We have long-acting beta agonists. We have inhaled steroids. And now we're going to come over here and talk about the anticholinergic, antimuscarinic agents. Those are just 2 words that are used for the other groups of medicines like ipratropium and tiotropium. Ipratropium Atrovent, sometimes combined with albuterol to be Combivent, a short-acting bronchodilator. And the long-acting 24-hour antimuscarinic bronchodilator, tiotropium, which is Spiriva, the pill that many of you breathe in. Spiriva has been shown to decrease exacerbation frequency as well. So now we have 3 options to decrease exacerbations. That's Spiriva, the long-acting beta agonist, and the inhaled steroids. And when you put those 2 together, that's Symbicort and Advair. And I actually have left one person out. You know, I'm all about fairness here, is that Merck just came out with another combination beta agonist, which is Foradil with an inhaled steroid. And theirs is actually called, what is it called? Dulera, yes. So Dulera is our third combination product here on this side. So I shouldn't have started down this pathway because I can talk all day, but so it's Advair, Symbicort, and now Dulera are our three combination beta agonist and inhaled steroid products. What's coming down the pike are triple combinations. We're going to put the anticholinergic with the beta agonist, and we're going to put the anticholinergic with inhaled steroid. And these are available in India now through CanadaDrugs.com. You can get all sorts of different combinations of all three of these medicines. And importantly, the FDA wants to make sure that these drugs don't interact in the canister and the dose per puff is exactly the same and all the details of what inhalation device is coming, and they're all very expensive. And I think one of this movements has been to try and get drugs through the FDA has really raised the price of the medicines, even though we all value the FDA for their attention to safety, but it comes at a cost, and that cost is the cost of medicines that we have to pay for in the United States compared to the rest of the world.
You mentioned someplace.com. I don't want to say which one, but are their medicines getting from there as safe as what we're getting here?
Well, y'all have been privy to all this news about the shortage of drugs that are hitting our hospitals these days, and it's very real. And so we've had one of our research trials this past month stopped because the drug is sitting in Great Britain, but it can't get through FDA inspection quick enough to make it to complete our trial. We had to put our research trial on hold because the drug is sitting at this loading dock in Great Britain, and it has to be FDA inspected before it comes across. And when they take a canister out, they have to go through all their testing. And it comes, and yes, I think they're probably safer by a little bit. But the rest of the world doesn't do this. You know, they draw their drugs from all over, and they have a much more competitive drug market. And as a result, the prices are about 10% of the prices in the U.S. And so, you know, what's more important? Is it safety, or is it in drugs that are 90% cheaper? And I think that whole process is part of this discussion around regulation in Washington and whether we put Michelle at the head of the FDA or whether we, you know, it's just how much regulation do we have and is it doing the right things there? And I actually think that the FDA serves a tremendously great job with the safety of all of our drugs. And so this is one of these social debates that we really have to go forward. If, for instance, the Medicare panel that's now meeting decides, well, we're going to take out all the drugs for rare diseases, because we have to cut the Medicare budget by 50%. Wouldn't you rather open up all drugs to an international market as a better way than take out all of your infusion drugs for rare diseases? And I think that debate about how we save money in the medical system has to happen at some level. And whether it's by loosening up on FDA regulation or whether it's by using foreign drugs or, you know, or limiting access to some drugs to a population that really needs them is going to be part of that debate. Reed.
Any evidence that hypertonic saline may be beneficial in the Alpha-1 group in terms of helping mobilize secretions and reduce the bronchiectasis effect?
Yeah, so great question, Reed. The question is whether a saltwater solution called saline at either 3% or 7% that is actually manufactured in these little vials like you put in nebulizers can help with Alpha-1. And when we start talking about expensive medicines, what do we think about salt water? Yeah, so we've got a little thing that we can make the salt water, we boil some salt on our stove, put it in a bottle, put it in our nebulizer, total cost 3 cents. Means that it might help. And the way hypertonic saline means salt water more salty than our own body secretions work is we put salt in the airway and it draws in fluid from the other parts of our lung back out into the air tubes where then we get juice that we can cough up. And so it's a way to decrease the mucus, particularly in these diseases like cystic fibrosis, bronchiectasis, and might as well work in Alpha-1 bronchiectasis if now 90% of patients with Alpha-1 have some bronchiectasis. So if we're having mucus problems, it's one of the things we do turn on that's very cost-effective because salt water is cheap, and yet when we inhale 7% saline, it can be an irritant. It makes you cough. And 7% saline is just very salty and brings lots of fluid in, and some people get a lot of wheezing around that. So as you know, we give bronchodilators before. We take our albuterol before we do our saline inhalation. It takes about 10 minutes to hook up to your nebulizer and put your salt water in, breathe it in, and then we want you to go out and exercise so you can then cough up all the extra water and clean out all the mucus that you've made inside your lungs. So we'd actually have that as one of our cheaper options compared to these very expensive drugs for a lot of patients that have bronchiectasis. So how many people in the room are using a saline solution now and again? We have 4, 5, 6 hands going up, 7, they keep coming up. So the neti pot is the similar sort of thing for the nose. And we know that salt water is a cheap medicine for the nose, just like it is for the lungs. And to be able to get salt water into our nose, it brings in secretions into the sinuses and the airway and helps clean out mucus. So some people find it tremendously beneficial. That's the alternative of just getting into the shower and doing it with plain old water. But water is also very irritating to our lungs and our nose because it doesn't have any salt in it. And so finding that right salt content is what the neti pot and the 3% and the 7% saline are trying to do is get enough salt in this process so you don't injure the cells that line our nose and our lungs, while at the same time bringing water into the airways to be able to get all the mucus out. The next question is, what about hydrogen peroxide? And hydrogen peroxide, is one of those great things that you can buy over the counter is H2O2. That means we get extra oxygen, right? And yet it's a very good agent that kills germs, but it also actually kills cells. And so when people start trying to put hydrogen peroxide inhaled into their lungs, into their nose, bad thing. And yet there were maybe 10 years ago some doctors thinking that maybe if we put hydrogen peroxide directly into our bloodstream, it could clean out some of that atherosclerosis in there that's making our blood vessels clog up as we get older. And there were actually clinics giving hydrogen peroxide infusions because as a doctor, hydrogen peroxide is over the counter, it's not regulated, therefore must be safe, right? And yet I think we have we're aware of some lawsuits in the community and other things that didn't go so well, and we discourage hydrogen peroxide as a therapy other than for topical skin cleaning after you have an infection.
There was actually one not far from my home, and it didn't stay there long.
You got a question?
Yes. How about the prednisone? You didn't get into that when you take the pill. What's the safety issues with that?
So the question about prednisone is when and how long and what to do with prednisone. Prednisone is a steroid pill. Our body makes steroids itself from a small gland inside of our abdomen called the adrenal glands. Your body makes your own body's steroids in a form called cortisol. Cortisol is a chemical in our body that regulates blood pressure and keeps our airways open. When we take extra cortisol, we don't have as a pill, so we use other synthetic steroids to supplement our cortisol levels. Prednisone does decrease inflammation throughout our whole body. So when we look at asthma and bronchitis and all the different infections that happen in our lung, they're all associated with inflammation. Your airways turn red and raw if you were to go look down there with scopes when you get a really bad infection. And we know that prednisone reverses that inflammation pretty effectively so people can breathe. The problem with prednisone is all of its side effects, and those side effects are a long list, and it depends upon how much prednisone we use and for how long. So almost everybody can use a day or two of prednisone without very many side effects, but the things that happen in the short term with moderate and high doses are that our sugars go up in our bloodstream. So people with diabetes have problems with their sugars going up. We can't sleep at night, so it makes us stare at the ceiling all night long. Some people with high doses go cuckoo, and they have hallucinations. They hear voices, they hear things, and people with schizophrenia, for instance, can really decompensate on prednisone. And so everybody's pointing fingers now around. But it's one of these things where prednisone, I call it the emotional roller coaster. It's, everything has to be a real high or real low, but that's part of prednisone's acute activity. Over the long term, it makes us hungry and we gain weight. The weight falls in funny places, kind of around our face and central obesity. But it means that your metabolic rate, you have to eat half as much food while on prednisone to keep your weight the same. So that's a hard thing to do, to instantly go to half as much food intake as you otherwise would. And over the long term, it makes our bones soft, osteoporosis at risk for fracture, and makes our skin thin. And our skin thinning sometimes means we get bruises all the time in our skin. We get cataracts from long-term steroids. So the point is that the list of long-term side effects is such that we really don't want to be using prednisone, except for these little short-time bursts that we use to get through exacerbations with or without antibiotics. In Europe, they use little 3-day courses of prednisone for almost every exacerbation. In the United States, we use a bunch of antibiotics and sometimes prednisone, and yet their exacerbation frequency is just the same as ours. The duration of exacerbations is the same as ours, and so it's just that different parts of the world use a lot more prednisone than we do for short periods of time without all these antibiotics that we use as part of our treatment of exacerbations on this side of the Atlantic. Jim.
However, I guess my question centers on a newly diagnosed alpha. It seems as if when the standard of care seems to be, once they're identified, we make sure that they get the right medications, and secondly, they're put on, if they're ZZ and their lung function is falling, they're put on augmentation therapy. However, the other pieces, such as pulmonary rehab and exercise, diet, and those kinds of things are secondary things that are kind of taken care of later. Should there be a standard of care, or is there a standard of care for a newly diagnosed alpha that would encompass, that they not only go on the right inhalers or therapies, but also the augmentation therapy, along with, a requirement for pulmonary rehab and that kind of thing to make sure that the total package is taken care of at the same time?
I think you're right on, Jim. This is one of these, some clinics do it really well and some don't do it so well. But to take remember that this is a COPD diagnosis first due to Alpha-1, to take all patients with COPD and think about them the same way. Historically, we've done a step care approach, the way we do in asthma. And in asthma, when your kid comes in coughing and wheezing, we say, well, here's an inhaler. Come back and see us in a few weeks and see if it helps. If it's not better, then we're going to add this inhaler, and now you're on 2 inhalers. And you're still not better, we add a little bit more, and we get you finally controlled. In COPD, our guidelines say, well, you should do the following 14 things. Let's start them all today. And yet when we start 14 different things all on the same day, people go, whoa, I'm overwhelmed. But it's the way that our guidelines read, is that we really should be taking a much more comprehensive approach. It starts with your pneumonia shot and your influenza vaccine. It goes through your bronchodilator inhalers, your therapies to prevent exacerbations. Everybody should start pulmonary rehab. Let's talk about your nutrition and your augmentation therapy and make sure every one of those little check boxes is done. One of the new things coming through Medicare, Office of CMS, is actually to recognize that if you show up at a hospital and we don't check all those little boxes and you come back to the hospital within the next month, they're not going to pay us anymore. So there are some programs that have developed. For instance, there's a really good one in western Pennsylvania that has put together 18 hospitals in a COPD care continuum driven by nurses and respiratory therapists to make sure all those little boxes are checked. And if they do, what they've shown is that they can decrease trips to the hospital by 80%. 80% less Medicare dollars going to the hospital means 80% more care given to the patients that don't have to go to the hospital anymore. So how do we do that? Well, is it to call up your doctor about 3 times a week and ask for more stuff? Well, no, we've got to change the way we do business. It's not all about the doctor anymore. We have to build healthcare teams that involve our respiratory therapy staff that we were very happy to see come out today. There's a lot more to just your visits than the doctor. It's the clinic nurse, it's the doctor, it's the whole program that checks all those little boxes at the time of diagnosis, not only as you get better or worse over time. So it's a very important change in healthcare that's happening right now, and it needs to happen better. Next question, and it's the last question because all of us are tired today.
It's recorded.
I think, isn't there a study, a gene therapy study, where they're injecting Alpha-1 into muscle groups? And I knew a little bit about it. I was just curious if there's any update on it and what the results are.
Okay, so the gene therapy studies are trying to make factories of Alpha-1 that live inside of our bodies so that we don't have to get weekly infusions of augmentation therapy. And so these studies first started in cell cultures down at the University of Florida. The lead investigator there is a fellow named Terry Flott, F-L-O-T-T, who moved from Gainesville, Florida, up to the University of Massachusetts. Dr. Flott, if you remember the research registry, you got the invitation to go up there and get injections of a gene vector, which is an adeno-associated virus carrying the M alpha-1 gene that he injected right into the muscle, and that MM gene went into the blood cell, into the cell of the muscle, and that muscle became a little factory to pump out a little bit more MM alpha-1. If your blood has ZZ alpha-1, then the extra M alpha-1 would be normal alpha-1, and if you could put enough of it and make the muscle a little factory, you could then turn on the machine and we see how long it lasts to be able to then pump out enough alpha-1 so that you'd never have to go back for another infusion again. Right? So they started this is gene therapy, they started with the safety piece in mind, right? And so let's give you one injection, see what happens. Had to follow them for 2 years to make sure no tumors happened in those muscle groups. Looked clean. So now they go to 10 injections, and the most recent injections were 100 shots into different muscle groups to get enough of a gene vector into the muscle to be able to make the muscle into a factory. What we know about right now, because they haven't published for about 3 years and they haven't published their most recent data, is that they can detect M alpha-1 antitrypsin in the bloodstream of these individuals. We don't know if they're going to be able to make the factory produce enough M antitrypsin to actually turn into a factory that has enough alpha-1 to be clinically meaningful or not. And so all these things kind of go to our big medical journals, Nature and Science and the New England Journal of Medicine about, this is something that's either going to all of a sudden break into the news tomorrow or, oh yeah, we just made a little bit more alpha-1. Now we need to do 1,000 injections into your muscles to turn the factory on big enough, or whether we come up with something newer and different. But those studies are all going. They need volunteers. Not everybody's willing to stick their leg out for 100 shots of an adeno-associated virus gene vector, but this trying to figure out the next step is what we're all about.
And could I just ask one final optimistic, hopeful.
Since this, Marlene, yes.
We just saw an article that came out about stem cell, new developments in stem cells from Dr. Lomas. Could we just hear a little brief about what that is?
For all of us in the Alpha-1 community, we think this fellow named David Lomas, who works out of Cambridge, UK, is one of those superstars who might win a Nobel Prize someday and shine Alpha-1 to the world. He really does a great job and has about 20 little doctors working all underneath of him in his labs in Cambridge. But what he's been working on is the ability to take a skin biopsy and take the cells there and turn them into stem cells that can be made into any other kind of cell in the body. So last month his publication in Science was that he took skin biopsies from Z Alpha-1 patients, cultured them in a petri dish, went in and changed the Z genes to M genes with a vector, de-differentiated those skin cells into pluripotent stem cells, and then reprogrammed them into becoming liver cells. Isn't that cool? And so now he's got a culture of liver cells that presumably all he'd have to do is put them in that portal vein inside your belly and they'd go up and populate the liver. So they haven't done the human piece yet, but they're kind of getting all this down. It's the machinery of how we're going to be able to do some of this stuff in the future. And everybody's saying, wow, can I have that done tomorrow? And yeah, it's not, we're curing those mice pretty well. But the amount of money that it takes to do this, how it's all going to work, all yet to be explored. But it's the kind of neat new science that we all like to hear about, particularly when it's working in our disease, Alpha-1. And there's a... So so any way to get the DNA into another cell's DNA is tough to do. If you just inject native DNA into a group of cells, it doesn't always get into the middle of the cell and get into the nucleus of the cell and insert itself. And so the way we sometimes do that is with viruses that bring the DNA into cells, and that's the way a virus replicates. So it kind of gets the DNA into the middle of the cell in the place that it needs to be to insert itself into those nuclei and into the DNA of the cell, your target cell that you're trying to go after to change its genes on the inside. So it's that's the tricky part about this, is trying to get to the right place, and how many cells, how efficient your vector is a very important part.